Hello, respected medicals. Myself, Dr. G.R. Patel, Professor of Surgery, having 28 years of teaching experience, today we'll be talking about the typhoid perforations. Myself and Dr. Mitesh Bachani, Assistant Professor, and Dr. V.D. Goyal, the then third year resident. We conducted a study at Medical College and Society Hospital, Bhavnagar, on typhoid perforations, which was having very high mortality. So we studied the importance of Brooks ileostomy in those days, and it proved to be a game changer for typhoid perforations. We know anti-perforation is having very high mortality and morbidity, and the then existing management of perforation was difficult, and it was surgeon oriented with a poor outcome. So we conducted the study in almost 15-20 years back at Sati Hospital, Bhavnagar, and the findings we'll be discussing here today. Dr. G.I. Patel, Dr. Nitesh Bachani, Dr. V.D. Gohil at Medical College and Sati Hospital, Bhavnagar, and the results are presented here. Management of typhoid perforation. The study was conducted at Sati General Hospital, Bhavnagar between 1st November 2003 to 30th October 2006, involving 95 patients. 18 patients underwent ileostomy for anti-perforation. The frequency of perforation, as reported by various authors, ranges between 0.9 and 39%. According to Caesar et al., this perforation incidence of about 3% has not changed despite the advent of new methods and antibiotics for the treatment of this pathological condition. In India, the reported incidence of perforation is 0.9%. Intestinal perforation resulting from a complication of typhoid fever has always been a cause of concern because of its high morbidity and mortality rates. Even in the present era of medical advancement, typhoid perforation continues to be a major health problem in tropical countries, commonly affecting young adults. Anterior perforation occurs in both the sexes, while male predominance and ratio being 3 to 4 to 1. In our study, the ratio was 5:1, suggesting male predominance. Increased exposure to the antigen might be the reason for male predominance. Being male is an independent risk factor for intestinal perforation, as suggested by Kozoglu et al. The patients who met with the criteria of typhoid perforation were grouped in two groups. Group A comprised of patients with typhoid perforation who were not having features that predicted increasing morbidity and mortality. Group B comprised of patients with typhoid perforation who were having factors that predicted increased morbidity and mortality. Factors which predicted poor outcome and included in the study were age less than 10 years and more than 50 years, duration of fever more than 20 days, duration of severe abdominal pain more than 48 hours, duration of abdominal distension for more than 48 hours, duration of oliguria or anuria for more than 48 hours, bleeding per rectum on presentation, shock on presentation, chest complications on presentation. In inotropic support are preoperative, intraoperative, or postoperative. hemoglobin less than 8 gram per son, total count less than 5,000 cubic millimeter per cubic millimeter, serum creatinine 2 milligram per son, bilirubin 1.5 milligram per son, peritoneal contamination of severe degree and fecal content, perforations of more than 2 centimeter in size and more than 2 in number. The average duration of fever in group A was 12.2 days, whereas in group B it was 22.6 days. Perforation in early period of the disease may be because of high virulence of the Salmonella strain. Since the outcome in the terms of complication is poor in group B, duration of fever more than 3 weeks should be regarded as a factor indicating poor prognosis. Abdominal tenderness, guarding, and distension are usually present, but it should be emphasized that there were several people with scaphoid, minimally tender abdomen who underwent laparotomy and were found to have diffuse established peritonitis. The physical examination was therefore not totally sensitive nor. So, resuming the typhoid perforation description, viral reaction is positive in about 50% of cases, and neutropenia is present in only 12% of cases, questioning the diagnostic role in typhoid perforation. In our series, abdominal tenderness and guarding were universally present in all the patients. No other findings in clinical examination was diagnostic of typhoid perforation. Moreover, serum viral reaction was positive only in 45% of the cases. Classical picture of neutropenia, relative lymphocytosis was present in 20% of the patients. In our series, also laparotomy was the ultimate diagnostic tool. Basson and Stockenberger reviewed the literature published after 1960 on typhoid perforation in different developing countries, with special attention to the incidence and outcome of typhoid perforation. They reviewed 1,990 cases of typhoid perforation published in 52 reports all over the world and concluded that the mortality is nearly 40%, and several authors have mentioned the mortality rate ranging from 20 to 40%. The causes for such mortality and morbidity have always been debated. Apart from causes like septicemia, myocarditis, depressed immunity, and others, some peculiar causes are also responsible in our country. They are late presentation, the initial manifestation of typhoid like mild fever, mild headache, abdominal pain are often neglected and results in delayed presentation. Moreover, people living in remote and rural areas, as they are not having access to the medical facility, present to the medical facility when the disease becomes complicated. Delayed diagnosis. The vague initial manifestation and resemblance with other common pyrexial diseases like malaria, cirrhosis, and viral hepatitis results in delayed diagnosis. The common available diagnostic tool, serum Vidal test, is usually negative during the first week of the disease, compounding the problem of delayed diagnosis. Delayed treatment. Lack of access to the proper medical care results in delayed specific management. Incomplete treatment. Typhoid is notorious for relapses, 10 to 20%. Chronic carrier state is also known. Once the patient becomes asymptomatic, he or she stops the treatment and the result is a relapse. Lack of immunization against typhoid fever, poor sanitation, hygiene, nutrition, and overcrowding, emergence of MDR typhoid, preoperative management about typhoid perforation for typhoid perforation. This includes vital data of the patient recorded, a big vein cannulated in the forearm of the patient with 18 gauge IV catheter, blood collected and sent for battery of investigations and cross-matching, need by mouth, oxygen with nasal bronchs at 4 liters per minute in patients with shock, Ray's tube insertion for nasogastric decompression, urethral catheterization for measurement of urine output, fluid resuscitation, management of typhoid perforation, fluid resuscitation. Typhoid ileal perforation is a life-threatening gram-negative septicemia with severe peritonitis. Patients of typhoid perforations are always fluid depleted because of third space loss, accompanying toxemia, fever, and abdominal pain. Fluid resuscitation is a must in all cases of peritonitis prior to induction of anesthesia for a better outcome. Intravenous infusion of the crystalloid solutions finger-ducted started in all the patients. The rate of infusion depends on blood pressure on presentation, urine output, right tube output, fever, degree of dehydration on presentation. Prior to induction of anesthesia, all patients received at least 2 liters of intravenous crystalloid and if needed colloid for restoration of depleted fluid volume to normalize oxygen carrying capacity and a better outcome for anesthesia. After reviewing literature, we classified the patient in two groups. Group A comprising of patients without added risk factors and Group B comprising of patients with added risk factors. We treated both groups aggressively. Antibiotics regimes used in both the groups were different. There were only one death in the study. Mortality was very low to only 2%. Since 1992, resistance to multiple antibiotics among isolates of Salmonella typhi has become an increasingly important and serious problem. Resistance to the first line of drugs is widespread now, especially in the Indian subcontinent, where 60 to 65% of Salmonella typhi isolated are MDS. Regarding management, continuing, we have reviewed the literature available to us and summarized the results in the following table. It is apparent from this review regarding diversity both of procedures and opinions regarding management and variable outcome after surgical management. This is the table where we did the primary procedure we followed from 1981 to 2004. So recording in progress about typhoid perforation. The differential diagnosis includes perforated appendicitis, mucus diverticulitis, intestinal tuberculosis with perforation, perforated peptic ulcer, and several others. In our series, perforated appendicitis was the most common finding, followed by intestinal tuberculosis with perforation other than typhoid perforation at laparoscopy. Continuing with the typhoid perforation management, while the increasing resistance to Salmonella is a global problem, monitoring and management will be a local problem. In this we have discussed lack of awareness, identification, and documentation of the problem, realization of the magnitude of the problem of drug resistance, microbiology services are not at all satisfactory, antibiotic policies are not well defined, lack of standardization of antibiotic usage, very scanty data regarding drug resistance, infectious diseases. The consultant was a specialty hardly exists in India. Antibiotics are prescribed by homeopathy and Ayurvedas who are indulged to practice modern medicine, untrained pharmacists or compounders who learn only from promotional activities of drug representatives, also do the same harm to the community. Over-the-counter OTC drug antibiotic supply without any valid prescription, use of poor quality of drugs, expired or degraded drugs, or even adulterated drugs pose a problem of growing magnitude. The patient often turns away from reputed brands because of the high cost. Moreover, MDI strains of Salmonella typhi are somehow more virulent. This was supported by the Pakistan data in which patients with MDI Salmonella typhi had higher morbidity scores. Our series confirmed the above statement and we found 76% of the isolates to be MDI strain. But in contradiction, there was no difference in morbidity as well as mortality as compared to patients infected by sensitive strain. This may be because of antibiotic regime we use. We have used a combination antibiotic therapy for all the patients. We have used third generation cephalosporin like ceftriaxone, cefoperazone as injectable form and cefixime as oral form. Efficacy of these drugs has been proved beyond any doubt by several clinical trials. We have used ofloxacin instead of ciprofloxacin because ofloxacin has shown very encouraging and excellent results in several trials. Compared with other clinicians, it completely eradicates the bacteria in short duration. Early eradication of bacteria is very important in preventing a chronic carrier state. Ciprofloxacin resistance is an emerging problem and the effective dose is debated, so we have avoided use of ciprofloxacin in our study. Typhoid perforation is a fulminant peritonitis with enterogenous organisms, both aerobes and anaerobes. Combination chemotherapy is always warranted for effective management. Along with anti-typhoid agents, we have used amikacin, a potent antimicrobial agent against gram-negative organisms, and metronidazole, an effective antimicrobial agent against the anaerobe. Authorities in this subject have tried their best to reduce the morbidity and mortality related to antiperforation. All have agreed to predict morbidity and mortality very in advance so that tailored management can be employed and complications are minimized. Grading of severity of acute peritonitis has assisted in no small way in decision making and has improved therapy in management of critically ill patients. The ability to objectively estimate patients' risk for mortality or other important outcome is an important part of managing severely ill patients. Empirically based risk assessment for important clinical events has been extremely useful in evaluating new therapies and monitoring resources utilization and improving the quality of care. Patients with other concurrent illness like diabetes mellitus, hypertension, bronchial asthma, COPD, chronic renal failure, pulmonary or extrapulmonary TB, and HIV seropositive patients were excluded from the study. Patients who were diagnosed intraoperatively other than typhoid perforations like perforated appendicitis, COX, intestinal perforation, maybe cecal perforation were also excluded from the study. Patients who had typhoid perforations of colon were excluded from the study. Radiation Kanmi et al. Has used modified Apache 2 score for predicting the outcome and concluded that Apache 2 score is helpful in predicting mortality but not the morbidity in the setting of typhoid perforation. Honan et al. In the study to assess risk factors predicting poor outcomes and potential risk factors like age more than 40 years, gender, inadequate treatment, duration of symptoms, high fever, more than 38.5 degrees centigrade, elevated transaminase levels, hepatosplenomegaly, anemia, leukopenia, and ESR, and concluded that the most significant factors affecting morbidity, prolongation of perforation of recent interval, and severe anemia. According to Sitaram et al., there are three adverse prognostic factors: long fever perforation interval, long perforation surgery interval, multiple perforations. Shukla et al. Found that the important prognostic indicators were patients requiring preoperative blood transfusion, presence of preoperative shock, and gross peritoneal contamination. Investigations in a case of typhoid perforation. These are hemogram, total WBC count, sensitive WBC count, neutropenia, parasite positive, platelet count, which is very important. ESR is usually slightly raised, random blood sugar. Typhoid test was not available in those days. Renal function test, including serum creatinine, was considered a risk factor for poor surgical outcome. Liver function test, serum bilirubin. These are the risk factors for poor surgical outcome. Serum vidal for diagnosis of typhoid fever, blood culture, radiological investigations, X-ray chest, X-ray abdomen standing for gas under diaphragm, X-ray chest for bronchopneumonia, ultrasonography abdomen for free fluid in the peritoneal cavity. Management includes intravenous antibiotics, fluid therapy, blood transfusion, fresh blood is preferred, inotropic support, blood transfusion, fresh blood is preferred, supportive symptomatic care. These are the drugs which were used, including ofloxacin, cefoperazone, sulbactam, amikacin. Operative management of typhoid perforation. Controversy still revolves around optimum operative management of typhoid perforation. Some sporadic articles mention success with non-operative management, but in our study, all patients underwent operative management under general anesthesia. Operative procedures which were carried out are enumerated below. Definitive procedures. Debridement and simple closure of perforation in, in two layers. These are the indications. Resection and anastomosis of the ideal section, depending on the condition of the patient. Peritoneal lavage was carried out after definitive procedure. Peritoneal drainage. We succeeded in our aim by reducing mortality drastically to just 2% by predicting poor outcome very in advance and tailored approach for each patient. It is generally agreed that typhoid perforations is high morbidity as a leading cause. In our study, Morbidity was as high as 65%. Ileostomy, the gold standard. Contrary to popular belief, ileostomy is a basic weapon to reduce mortality when poor outcome is predicted. It did not add to the morbidity in our study. Ileostomy decreased hospital stay as compared to resection and anastomosis. It was associated with lesser problem, postoperative complications like pancreatic illness, residual collection, pulmonary complications. Patients with ileostomy were allowed orally on early and they were ambulatory. During our study, section anastomosis was the procedure associated with highest morbidity and mortality. Based on these observations, we strongly recommend ileostomy as a preferred option in patients having risk factors predicting poor outcome. Moribund look of the patient with typhoid perforation. Primary closure, no, no resection anastomosis. Typhoid perforation with mesenteric lymphadenitis. Typhoid perforation, big typhoid perforation. Photograph of the typhoid perforation. Big peritonitis. Severe enteritis with typhoid perforation. This is two-layer closure of the perforation. This is loop ileostomy. Ileostomy. Primary closure of perforation with proximal loop ileostomy. Ileostomy. Unhealthy margin, inflamed base, typhoid perforation. This is John M. Brook photograph. Loop ileostomy with mucus fistula. This is a diagram depicting loop ileostomy procedure. Complications of ileostomy. Wound infection. Ostomy care was an isolated field until 1950, even in developed countries. It was only in 1975 ostomy care was inaugurated in India at Mumbai by formation of Ostomy Association of India. The association was started at Tata Memorial Hospital under the aegis of Indian Cancer Society. This was the society that was formed. Now there are multiple ostomy associations and there is a association at Tata Memorial Hospital. World Ostomy Day, 7th October. It is celebrated every year from 2006, 7th October. Under the theme Living Life to the Full, World Ostomy Day will be celebrated in more than 30 countries all over the world. World Ostomy Day is celebrated